Now, my pleasure to present that. More than 25 years ago, I've been producing what's funny in African Indian and Chameleon area. In the senior professor, senior global geologist, and Mexico, Institute for Alaska Health and Sweden. This project has made it one of the causes that has been a big deal and three program the 21 year in the cyberspace international industry by being stuck. But then the next one, my team, my mountain region, was on platform. My visit to Mrs. Human by the
So much. To be here in this fantastic and historic city. First visit, I'm grateful for your organization. So, I will have to say next, yes, certainly. Okay, can I have the first slide, please? So I've been asked to, or proposed to make the case for early use of high efficacy therapies. There is, of course, a growing body of evidence in this field, and I have to forgive me for being subjective and contemplating good things I've been involved in myself. Next slide, please. My disclosures. Next again, please. Next slide. Yeah. Next slide, please. Yes. So, next slide, please. Yes. So, just to make this very clear and very simple, the messages in this presentation will be that early initiation of disease-modifying treatments of MS is important, and early initiation of the highly efficacious DMTs is even and early initiation of the highly efficacious DMTs is even. And I have some secondary messages as well. I would like to convince you that systematically documented clinical information in a patient registry is a gold mine for improvement knowledge, for improvement comparative research. If I have time, I will also say a bit about languages between different registries and not really next slide, please. So I guess the reason why I'm standing here is probably this paper that the previous speaker was kind of told me. So so nice. As you see on the right hand side here, when we compared a few years ago the risk of MS patients in Sweden and Denmark to develop disability, the Swedish patients do don't have as bad as the Danish. Both these countries are small, have registries with all the patients almost in the country, and we have comprehensive publicly funded health systems, so no issue with access to care, for instance. So the difference was depending on the two treatment strategies: escalation therapy employed in Denmark, and the more liberal system in Sweden, where we could allow ourselves to use highly efficacious transport. Next slide, please. Yes. So this is, well, so how did this evolve? Well, this is from the Swedish MS registry. The use of DMTs ever since the late 1990s. You can see that the drugs have gone, but towards the end of this, the right side of this graph, you will see that most of the curves are going down now. So what was there? Next slide, please. Well, what happened was the introduction of rituximab. Even though rituximab was not formally used in MS. It has become the dominating treatment um, which is quite remarkable, I would say. Next slide, please. So the strength with this was, of course, a very nice paper by Stephen Hauser and his colleague, showing that rituximab almost eliminates new lesions. This was published in 2008, I believe. Yes. And then, with the use of rituximab and the registration of all these treatment episodes in the MS registry, we were able to show that comparing different treatments, that rituximab is indeed efficacious. I'm going to go back to some images later. In the bottom half here, we have also a registry-based RCT that is comparing rituximab to DMF technique, showing that rituximab was superior to detected area aspects. Next slide, please. And as a consequence of this increasing body of evidence, most or largely, I would say, registry data has led to an even to a change in guidelines. And next slide, please. And even the WHO, to my surprise and many people's surprise, has been put on the list of has put rituximab on the very brief list of necessary medicines for MS, even though it's still not today licensed for this. That's peculiar. Next slide, please. So, a few words about the Swedish MS registry. We've been around since the late 90s, additionally since for 25 years. It's voluntary, but it provides myself and my colleagues with a summary of the patient case, which makes it clear among colleagues. And that's what we use. Next slide, please. It contains a number of different things. Demographics, different color coding, and you see the color bars on the bottom, those are the DMTs, for instance. So before I go out into the waiting room and ask my patients to come into the office, this is what I open up. I get a very brief, very quick reminder of where this patient is. Next slide, please. So with the time, we've collected lots of data here. We have 24,000 patients, 175,000 EDS scores, etc. 45,000 treatment episodes, and patient reported outcomes, cognition screens. And this has led to a number of different publications. And one registry-based randomized trial. So quite a nice body for data research. Next slide, please. So what we can also do in Sweden is that we can link this clinical data, the register data, to other data from the right-hand side public databases of various kinds, and also to lots of discovery things like genomics and other omics. So it's a rich body of resources here. Next slide, please. So if you look at the registry, you will see that things are getting so much better for patients. If I had a pointer, I would show here the average decrease of EDSS in the registry, the dramatic drop in relapse rate, the risk of converting to SPMS, the drop in causes of disease. On the right-hand side, it's a sort of a complicated figure, but it shows that every new yearly cohort of newly diagnosed patients fares some percent better than the year before. So over 15, 20 years, this is a huge difference. And we have some unpublished data on the cost of MS, and they go down dramatically in the past few years. So this has continued. Next slide, please. And this is, of course, not possibly due to new diagnosis criteria, but very, very likely to the expensive use of DMTs. We all were uncertain if we go back 30 years when these drugs were really useful. And that's when we started the registry, along with other registries. This was the first convincing study we had, I think, when we compared the the importance of storing early compared to storing later. And you can see that just a year or two in difference in storing time makes a big difference 10 years later. This is something that an RCT can never do. You have to have registries to do this. To see this. Next slide, please. And this was then extended to the importance of early initiation of secondary sort of highly efficacious drugs. On the right-hand side, you can see that people receiving early, highly efficacious drugs fare better, regardless of how you define the story. Quite convinced this was a collaboration between the MSAs and Oregon County's shots for this. Next slide, please. What we have done then in the Swedish setting is that we have compared all the various treatments. And you can see here that when it comes to people, well, effect on relapses, rituximab is by far the best. The right-hand side, you can see that when it comes to disability, it's less of an obvious difference in this way, but there is a difference. There is a significant difference. And that's even though it's complicated to make these comparisons in a population where people change more and more again, as you can see on the right-hand side. But it's quite clear that rituximab is better in those places. It has one disadvantage. It doubles the risk of serious infections. But 90% of patients don't have serious infections. So that drawback is less important for the population at large. Next slide, please. So going back then to the difference between the Danish and the Swedish system. In Denmark, they have a very hard, like they say, you have to struggle with this, you have to struggle with that. Many years to send you had to struggle with teriflunomide. That was considered the so very clear an escalation reach. If you see on the table here, the distribution of both different mixers, but diverse in the Danish stomach mine. Whereas it's really we allow ourselves to start patients earlier on mechanism have brilliance. And in that we can see by scrutinizing the details, that's what made the difference. So this is a very good, very strong argument in my mind to the importance of really with highly efficacious drugs. Next slide, please. Yeah, when it's made the same comparison with the Czech, Czechia, where they have also the use for the skin with the and you can see the same difference at a slightly similar scale, but still quite clearly an advantage of highly efficacious drugs for others. Next slide, please. So we have seen those two things already. And next slide, please. So what these other things? Next slide, please. Well, we have this some of that, yeah. We have been collaborating between different mature investment investors for many years. The new work being staying very but so really is it. Next slide, please. We came together in 2014. We were the Swedish and the Danish, and the French and the Italians and the Czech, and of course MSBase, which is run from Australia, but it's an international network by centers, and there are three centers in Saudi Arabia also that were in MSBase. Some of these results are also yours. Next slide, please. Many of these registries were started or at least upgraded when the DMTs arrived, with the purpose of actually studying whether these drugs were of importance for them, how, if so, how were they to be optimally used. And we've been working together. We have been able to merge data even physically. We have mapped the variables that we have, the definitions, we have a common data model. Next slide, please. So even though each of the registries have their own data models, next slide, please, we have been able to put this together in a comprehensive common data model which allows ourselves to analyze the data in a illustrated way. Next slide, please. This shows how you do it. We have a common data model dictionary. We have a mechanism of translating into the same format and also logging the success rate of transformation. And then we have a validation log indicating the quality of the data. Next slide, please. By doing this, we have been able then to jointly analyze data. And this is something that is over the start. This is what's going to be very typical in clinical research in general. We will have to merge data from different sources. We will be able to do that. I will tell you in a minute. Like this. And it's in Europe, of course, dominated by the scary product of the European health data space. And this is something that has been already agreed. We will have to be able to share data across European borders in order to care for the individual patient. And then secondarily, we will be able to use that also for research, for improving our care. That's a tremendous. It means that we have to align all our definitions. We have to build up IT systems that allows exchange of data. So it's something that is theoretically possibly simple, but in fact requires a real challenge. And this will really revolutionize how healthcare is being performed, but also how clinical research will be. Next slide, please. So about way. Gives us the sense of the complexity of this. So far, even hospitals are not necessarily digitalized in terms of electronic medical. But if all the medical records in all the hospitals around Europe, 29 member states of the EU are to do this. This is a fantastic effort. Next slide, please. Yeah, all have to speak the same very language. That will happen. But it will take time. Theoretically, this should be in place in 2029 when it comes to primary use, in 2031 for secondary use. Most of us believe it will take longer, but I'm sure it will happen. Next slide, please. And next slide, please, again. Because the future that we are approaching is very clearly digitalized. There will be built-in mechanisms in the IT systems that we use. And if you take the next slide, please. When you talk about the registry, it's not a very sexy word, many people think about that. Next slide, please. The main of the registries that we have are still just archives. Next slide, please. We believe that the registry should be rolled out, should be used to be back. Next slide, please. Clinical records were quite recently in our hospitals paper-based. Some of us have had electronic medical records now for 25 years. Some still have papers. Next slide, please. This is, the properties that some of the registries have is probably what the EU is doing now. Because this is so superior just archiving information. You need an electronic medical that makes statistics, summarize patients' information in a useful way. Next slide, please. And this is where we're going. We will, in our medical records, in all our systems, MRI systems, image systems, as well as laboratory systems, have automated functions that allows information to be integrated. We will be able to build into this system also decision support, properties, prediction tools. We'll have interoperability, meaning that different data sources will work together. There will be built-in quality control. There will be built-in audits of sample work. I'm sure there will be built-in semi-automatic research engines that will change the way we perform research. but this is removing, and there's no going back on this thing. So next slide, please. Thank you for your attention.
This representation, today, talking about money and thanks for the instant blame. Is the first band of the JC, that constraint properly, and it's the capability of some key is not the high and you can trust me to document it from my university of building in this leading global frontline leaders, including then we will transform it, the information by necessity and the rights faculty of really leader. One of the most things that my office in your CV is that innovations and outcomes. Actually, this regarded is a leading innovator in digital health on AI-driven medical transformation. So please come with me, Dr. Matthew, and be with us for the future of consulting customers and utilization of AI in our technology and this. That was the thank
me and Medina in this school. And that means I'm not a neurologist, I'm a hematologist. But what I hope to convince you today that this course doesn't very working between different specialties is really, really important. And I hate just with an example of where neurologists and hematologists have come together to provide better treatment options rather than for this to know about this we do. What he's been saying is the EDSS score, which comes up, which is now stable, patients ultimately worry about the downward spiral in their functional ability. That's the thing that scares patients in this field because it's in that don't realize because as a cancer patient who's all about surviving, as a neurology patient, it's about living better and living with better health. In fact, we gave a book earlier about the entomologist from the British Museum who documented his history of events. And in fact, I went to a book written by a professor of English literature at Oxford University called Robert Williams Clare has been read in mental illness, which is really interesting based on the comparison between this British entomologist and how his life was transformed on the HSCT numbers. Anyway, what is HSCT numbers and why do I think it's important? Well, it's one of the most exciting times to be a doctor at the moment because the recent information available new development and new technological advancements is the medical knowledge that doesn't really know about medicine today. It's going to double within 73 days. So this is the most exciting time to be a doctor. And if you're looking at options here, you can see in MS, in the last decade, there have been a huge increase in different treatments in the year on year. The one that's probably the most significant patients is probably HSCT or autologous stem cell transplantation. It's also the most difficult to deliver. Now, if you have a graphic there, what it's showing is what's the difference in HSCT in what's really big names isn't different because if you look at most DMTs, they do move on the land breaks, and it's the best field break. And you Sometimes like information. Ultimately, the disease doesn't come real. Whereas with HSCT, what you're really going to do is induce immune tolerance and basically reset the immune system. And if you do that, then there's a possibility when it's not information. With a real speed, so you give more payment and you got a full information. Eventually, improve. I hope to show you, convince you, is that there is data to make that statement up. What is HSD for you? You don't know it's a two-stage procedure. So what I call my stem cells that can regrow your island. We're talking about stem cells that can regrow your immune system. And so with these cells are only housed in the bone marrow and don't bring mind to the blood. But what we do is we encourage them to mind to the blood by giving a combination of chemotherapy and it's something that we expect them to get like a good for instance procedure where we look at the framing now and then like the something extensive communication to the fluids when we link the media and link them completely and then we just tell them and link them and then this comes to your immune system. There's the innate immunity within the body within the